Okay, immune-mediated neuro disorder. First is multiple sclerosis. It's an upper motor neuron lesion and also known as disseminated sclerosis or encephalomyelitis disseminate. It's an autoimmune disease in which the body's immune system attacks the person's central nervous system, leading to demyelination. So main thing is demyelination. Disease onset usually occurs in young adults, females more than males. Four types of multiple sclerosis is there according to the onset. First one is relapsing remitting, characterized by unpredictable relapses followed by periods of months to years of relative quiet remission with no signs of disease activities. Deficits suffered during attacks may either resolve or leave sequelae. This describes the initial course of 85 to 90% of individuals with MS. When deficits always resolve between attacks, they is sometimes referred to as benign MS. So, this is the most common one, relapsing remitting. Primary progressive, approximately 10 to 15% of individuals who never have remission after the initial MS symptoms. No remissions. It's characterized by progression of disability from onset with no or only occasional and minor remissions and improvements. So there's no remission. The age of onset for the primary progressive subtype is later than other subtype. So the age of onset is later. Secondary progressive describes those with initial relapsing remitting who then begin to have progressive neurologic decline between acute attacks without any definite period of remission. Occasional relapses and minor remissions may appear. The median time between disease onset and conversion from relapsing remitting to progressive, secondary progressive, is 19 years. So this is the median time, 19 years. So this will be relapsing remitting followed by progressive. And progressive relapsing describes those individuals who from onset have a steady neurologic decline but also suffer clear superimposed attacks. Steady neurological decline but also suffer from superimposed attacks. This is the least common of all types. Okay, so now the steady decline. So this is about steady. Okay, now non-standard behaviors have also been described, sometimes referred to as borderline form of MS. These include Devick's disease, Baloconcentric sclerosis, Schilder's diffuse sclerosis, and Marburg MS. MS also behaves differently in children. There is debate whether these are atypical variants of MS or different diseases. So in multiple sclerosis, what features do you see? Basically, visual, sensory, motor, and cerebellar. So in visual, you'll see optic neuritis, common presenting features we studied in ophthalmology, optic atrophy, Uthoff's phenomena, worsening of vision following rise in body temperature. Uthoff, sometimes you have to remember somehow. Uthoff from the hot bath, worsening of vision following rise in body temperature. Internuclear ophthalmology, we know about it. And then for sensory, there will be pins and needles, numbness, trigeminal neuralgia, Lermit sign, paresthesia in limbs on neck flexion, Lermit sign, Lermit on your neck. On your neck. So you have to find some ways to remember these things, otherwise it will be difficult to recall during the exam pressures. Okay, motor will be spastic weakness, of course, upper motor neuron type, and primary progressive subtype is later than subtypes. Okay, cerebellar, there will be ataxia or tremor. Okay, others can be urinary incontinence, sexual dysfunction, intellectual deterioration. To remember prognostic features, the typical patient carries a better prognosis than an atypical patient. So good prognosis features, a very common question in the exam will be sex of female, young onset of age of onset, relapsing remitting disease, the first one, isolated sensory symptoms, that's good for us, long interval between first relapses, that's great. So the female, young age of onset, relapsing remitting disease, isolated sensory symptoms, long interval between the two relapses. Diagnosis requires demonstration of lesions disseminated in time and space, very important. MRI will show high signal T2 lesions, periventricular plaque. CSF may show oligoclonal bands and not in serum. Increased intrathecal synthesis of IgG. So, as you know, the plaques are there, tissue lesions are there, and oligoclonal band, and not in serum. Not in serum. Increased in ethical synthesis of IgG will be there. So, moving to the next part is visual evoked, delayed but well performed waveform. Okay. Okay. So, treatment in multiple sclerosis is focused at reducing the frequency and duration of the relapses. Therefore, there is no cure, so you only have to focus on reducing the problems that are occurring, the relapses. So, high dose steroids. Number one is methylprednisolone. May be given for 3 to 5 days to shorten the length of an acute relapse. Baclofen or gabapentin are helpful in controlling spasticity. So, particularly, it helps in controlling the spasticity. Hallucinations are occasionally seen in the withdrawal of baclofen, and withdrawal of baclofen you will see hallucinations. Number two will be beta interferon, has been shown to decrease the relapse by up to 30%. Certain criteria have to be met before it's used. Decrease the relapse by up to 30%. So beta interferon. Relapsing remitting disease, we have already studied this: alpha interferon, beta interferon, interferon beta, interferon gamma. So yeah, relapsing remitting disease plus 2 relapse in past 2 years. Okay, so but the certain criteria have to be met before it's used, like relapsing remitting disease plus 2 relapse in past 2 years. Secondary progressive disease, we have studied before. Secondary progressive disease and decreased number of relapses and MRI changes, however, doesn't decrease overall disability. Other drugs what can be used in multiple sclerosis. Using the management will include latrimere acetate, immunomodulating drug, natalizumab for the treatment only of rapidly evolving severe relapsing remitting disease. RES is defined as more than 2 disabling relapses in 1 year, and more than 1 gadolinium enhancing lesion on brain MRI, or a significant increase in T2 lesion load compared to previous MRI. Symptom control, spasticity like baclofen, gabapentin are first line. Other options include diazepam, dantrolene, and tiazanidine. Physiotherapy is an essential part of treating MS. Another autoimmune disease would be myasthenia gravis, and where basically it's an autoimmune disease. And what happens is it's an autoimmune disorder resulting in insufficient functioning of acetylcholine receptors. Antibodies to acetylcholine receptors are seen in 90% of the cases. Antibodies are less commonly seen in disease limited to the ocular muscles. Myasthenia is more common in the females. It's a neuromuscular disease leading to fluctuating muscle weakness and fatigability, in which weakness is caused by circulating antibodies that block the acetylcholine receptor at the postsynaptic neuromuscular junction. At 200 to 400 cases per million, it's one of the less common autoimmune disorders. The most common exacerbating factor is exertion, resulting in fatigability, which is the hallmark of myasthenia gravis. Symptoms become more marked during the day, and features are number one, extraocular muscle weakness like diplopia, double vision, proximal muscle weakness, face, neck, limb girdle, ptosis, dysphagia, and associations can be thymoma, autoimmune disorders, pernicious anemia, hypothyroidism, rheumatoid, SLE. So you have to remember the associations, very important. Myasthenia gravis and thymomas. Autoimmune disorder like pernicious anemia, hypothyroidism, rheumatoid arthritis, SLE, thymic hypertension due to 70%. Investigation is Stensilon test. IV etrophonium decreases muscle weakness temporarily. CT thorax to exclude thymoma. CK normal and anti-musk antibodies will increase. Management can be long-acting acetylcholinesterase like pyridostigmine. You can do it since there's antibody to acetylcholine receptor, anticholinesterase, which will increase the acetylcholine. Immunosuppression, prednisone initially, or sometimes it can worsen the symptoms, thymomectomy. And management of myasthenic crisis like plasmapheresis or intravenous immunoglobulins. You can see ptosis. Not ptosis, it's basically weakness in muscular, extraocular muscles. Yeah, that's causing ptosis. Okay, so drugs that may exacerbate myasthenia, it's beta blockers. This is a very important question. It comes in the exam. Beta blockers will exacerbate myasthenia gravis. Theoretical worsening based on propensity to cause slight effects of fatigue and weakness. Gentamicin, aminoglycoside, and tetracycline lithium. All these can cause problems in myasthenia gravis. Magnesium, penicillamine, phenytoin, quinidine, procainamide, verapamil, contrastigence, chloroquine, prednisone, all these will cause havoc for a myasthenia gravis patient. Okay, the next topic is Lambert-Eaton myasthenia syndrome. Very important topic, associated with small cell lung cancer and to a lesser extent breast and ovarian cancer as well. It may also occur independently as an autoimmune disorder. Lambert-Eaton myasthenic syndrome is caused by antibody directed against the presynaptic voltage gated calcium channel in the PNS. Calcium channel, PNS. Three important things to remember is presynaptic voltage gated calcium channel and PNS. Peripheral nervous system. Features can be repeated muscle contractions lead to increased muscle strength. So the more you work out, the more strength you'll get. Something like that. In contrast to myasthenia gravis, where the energy decreases. Ptosis is much less common in Lambert-Eaton syndrome than myasthenia gravis. And limb girdle weakness affects lower limbs first. Proximal muscles more commonly affected. So something which comes in the question very much. Hyporeflexia, autonomic syndrome like dry mouth, impotence, difficulty micturating. Ophthalmoplegia and ptosis not commonly a feature, unlike in myasthenia gravis. So eye features are less. Okay, so going back to the features, repeated muscle contraction will increase strength. Ptosis will be much less common. Limb girdle weakness, proximal muscle weakness, very important. Hyporeflexia, autonomic symptoms like dry mouth, impotence, difficulty micturating. Ophthalmoplegia and ptosis not common feature. EMG incremental response to a repetitive electrical stimulation. Okay, management is managed of the underlying cancer. Immunosuppression, for example, with prednisone or with azathioprine. Amifampridine prescribed by specialists only works by blocking potassium channel efflux in the nerve terminal so that the action potential duration is increased. Calcium channels can then be opened for a longer time and allow greater acetylcholine release to stimulate muscle at the end plate. IVIG therapy in plasma exchange may be beneficial. Okay, moving on to another very important autoimmune disease, GBS. It's an autoimmune mediated Guillain-Barré syndrome. It describes an immune-mediated demyelination of the peripheral nervous system, PNS, often triggered by an infection, classically Campylobacter jejuni, is usually a subacute neuropathy. Important, demyelination. Pathogenesis can be cross-reaction of antibody with ganglioside in the peripheral nervous system. Cross-reaction of antibody with ganglioside in the peripheral nervous system. Correlation between anti-ganglioside antibody, anti-GM1 and classic features has been demonstrated. So cross-reaction of antibodies with ganglioside in the peripheral nervous system and correlation between anti-ganglioside antibody and okay, so anti-GM1 antibodies in 25% patients. So it's usually a subacute neuropathy and precipitating factors can be Campylobacter jejuni, chlamydia, HBV, mycoplasma pneumonia, CMV, EBZ, HZV, HIV. Presentation presents subacutely over days to weeks as an ascending paralysis. Ascending paralysis very important as well. Noted by weakness in the legs, spread to the upper limbs and the face, along with complete loss of deep tendon reflexes. It may involve respiratory muscles leading to the paralysis, and prognosis 20% suffer disability, 5% die. So poor prognostic features can be age more than 40 years and decreases upper limb muscle strength. Guillain-Barré syndrome, upper limb muscle strength decreases, and poor prognostic factors, age more than 40, upper limb muscle strength decrease, rapid symptoms progression, previous history of a diarrheal illness, high anti-GM1 antibody titer, need for ventilator support. All these are poor prognostic features, very important. You have to remember this again. Management will be plasma exchange, IV immunoglobulin, steroid and not. Steroids and immunosuppressant and have not been shown to be beneficial. FVC regulate to monitor respiratory function. There is currently contradictory evidence as to whether a gradual or rapid onset of GBS is associated with poor outcome. Here it says rapid onset symptom progression. Okay, Miller-Fisher syndrome, variant of GBS and associated with areflexia, ataxia, ophthalmologia. So you can call it areflexia, eta off. Usually present as a descending paralysis rather than an ascending, as seen in the other forms of GBS. Anti-GQ1B, GQ1B, that is GM1, and GBS and GQ1B, it's the opposite, are present in 90% of the case. Okay, the next part is paraneoplastic syndrome affecting the nervous system. Lambert-Eaton myasthenic syndrome. So Lambert-Eaton syndrome is basically having some sort of paraneoplastic syndrome like small cell lung cancer, breast and ovarian cancer. Antibody directed against presynaptic voltage-gated calcium channel in the PNS can also occur independently as an autoimmune disorder. Increases muscle strength followed by weakness eventually. Okay. Increase followed by weakness. Okay. Anti-WHO, imagine 8 sticks as 2 lungs or 2 brain hemisphere. Anti-WHO associated with small cell lung cancer and neuroblastoma. So WHO born heroblastoma. Remember that, heroblastoma. Sensory neuropathy may be painful, cerebellar syndrome, encephalomyelitis. Anti-YO, imagine as Y as lady, private organ, associated with ovarian and breast. Remember this diagram. Cerebellar syndrome is both in anti-WHO and YO. Yo. Anti-GAT syndrome is translated serious. Remember, serious stiff person. So associated with breast, colorectal, small cell lung carcinoma, BCS. Stiff person syndrome or diffuse hypertonia, BCS. Anti-RE, remember that anti-RE is basically BS. BS. Breast and small cell lung carcinoma. Ocular opsoclonus myoclonus. Remember that. Next, for neurodegenerative disorders, basically Parkinson's disease. Okay, neurodegenerative disorders. Firstly, Parkinson's disease. Progressive neurodegenerative condition caused by degeneration of dopaminergic neurons in the substantia nigra. This results in the classic triad of features: bradykinesia, asymmetrical tremor, and rigidity. BTR. The symptoms of Parkinson's disease are characteristically asymmetrical. Bradykinesia, poverty of movement, also seen mask-like faces, difficulty in initiating movement, tremor, most marked at 3 to 5 hertz, most marked at rest 3 to 5 hertz, typically pill rolling, rigidity led by Gogwell due to superimposed tremor. So the reversible causes and irreversible causes and psychiatric disorders. So Cogwell, rigidity, reversible causes can be hypothyroidism, thiamine deficiency, all these things. Examples, psychiatric disorders, all these things are there. Other characteristic features can be, so these are actually causes of Parkinson's, dementias, I think, or maybe rigidity, I'm not sure. Okay, other characteristic features which are more important here can be flexed posture, short shuffling steps, micrographia, drooling of saliva, REM, sleep, behavior disorder, impaired olfaction. Psychiatric features like depression is the most common feature, affects about 40%. Depression, dementia, psychosis, sleep disturbance. Cause of Parkinsonism, Parkinson's disease, and drug-induced antipsychotic, metoclopramide, progressive supranuclear palsy, multiple system atrophy, Wilson's disease, post-encephalitis, dementia, toxins, carbon monoxide. These are the causes of Parkinson's disease. Drug-induced like metoclopramide, progressive supranuclear palsy, multiple system atrophy. We'll come to that. Wilson's, post-encephalitis, dementia, carbon monoxide, all these things. So important topic of drug-induced Parkinsonism has slightly different features. So what happens in drug-induced Parkinsonisms? Motor symptoms are generally rapid onset and bilateral. So it's bilateral and rapid onset. Rigidity and rest tremor are uncommon. So you don't see rigidity and rest tremor in drug-induced Parkinsonism. Drugs causing Parkinsonism can be phenothiazine like chlorpromazine, butyrophenone, haloperidol and droperidol. So in a patient of PD, you can't be giving haloperidol. It will be worsening the features of Parkinsonism. Metoclopramide, domperidone does not cross the blood-brain barrier and therefore does not cause extrapyramidal side effects. So this one does not cause any Parkinsonism, but metoclopramide can. Metoclopramide does not cause blood-brain barrier. Remember that. So management can be offered levodopa in early stages if motor symptoms have impact on quality of life. Consider a choice of dopamine agonists like levodopa or monoamine oxidase inhibitors if motor symptoms do not affect the quality of life. So firstly thing that comes is dopamine receptor agonist. What are the agonists here? Examples are given like pramipexole, bromocriptine, roperidol, a very common drug, cabergoline, apomorphine, ergot-derived dopamine receptor agonists like bromocriptine, cabergoline, pergolide have been associated with pulmonary, retroperitoneal, and cardiac fibrosis. So bromocriptine, cabergoline, pergolide (BCP) can cause fibrosis. BCP fibrosis. ESR, creatinine, CSF should be obtained before obtained prior to treatment, and patient should be closely monitored. And roperidol is least associated with tissue fibrosis. So this is the one which mostly used. Roperidol, you see. So since there's no fibrosis, this can be used easily. Patients should be warned about the potential for dopamine receptor agonists to cause impulse control disorders and excessive daytime somnolence. So what can be the adverse effects of L-dopa? Dyskinesia, on and off effect, postural hypotension, cardiac arrhythmia, nausea, vomiting, psychosis, in fact, the reddish discoloration of urine upon standing. Okay. And levodopa usually combined with a decarboxylase inhibitor like carbidopa or penesarazide to prevent peripheral metabolism of levodopa to dopamine. It decreases effectiveness with time, usually by 2 years. Unwanted effects can be dyskinesia, on and off effect, not used in neuroleptic induced Parkinsonism. Monoamine oxidase inhibitors like selegiline inhibits breakdown of dopamine. Inhibits breakdown of dopamine secreted by the dopaminergic neurons. Okay. Dopaminergic neurons, and abantadine is mechanism is not fully understood. Probably increases dopamine release and inhibits its uptake at dopaminergic synapses. So selegiline inhibits breakdown of dopamine secreted by dopaminergic neurons. So it inhibits breakdown. Mechanism is not fully understood, but increases dopamine release and inhibits its uptake at deep dopaminergic synapses. COMT inhibitors, entacapone. CMT inhibitors is an enzyme involved in the breakdown of dopamine. So CMT inhibitor hence be used in adjunct to levodopa therapy used in established PD. So this one inhibits breakdown of dopamine. This one increases dopamine release and also inhibits its uptake. COMT inhibits breakdown. Entacapone, antimuscarinic, blocks cholinergic receptors. Now used more to treat drug-induced Parkinsonism rather than idiopathic. So this is the one used in drug-induced Parkinsonism. Help tremor and rigidity. What do you get? Procyclidine, benzotropine, trihexyphenidyl. Procyclidine, benzotropine, trihexyphenidyl. This is one thing which is used very often. Drug-induced Parkinsonism. You can see procyclidine, benzotropine, trihexyphenidyl. Pergolide. Withdrawn from the US market due to concern increase in incidence of valvular dysfunction. Okay. Next is also very important topic. It's Parkinsonism, other features. MSA, multiple system atrophy. It's also called Scheidrager syndrome. It's a type of multiple system atrophy. So what really happens in multiple system atrophy? Parkinsonism, cerebellar signs, and autonomic disturbance. We'll say it again. Parkinsonism, cerebellar signs, autonomic disturbance. Parkinsonism, cerebellar signs, autonomic disturbance. MSA, PCA. MSA, PCA. MSA, PCA. Parkinsonism, cerebral signs, and autonomic disturbance. So like what? Atonic bladder, postural hypertension. So when you see these three together, think about this. Cerebral sign will be there, atonic bladder, postural hypertension, or Parkinsonism. Okay. Another one very important is progressive supranuclear palsy. So we have to know that there is vertical gaze impairment. It's a degenerative disease involving the gradual deterioration and death of selected areas of the brain. Both female and male are affected approximately, and there is no racial, geographical, or occupational predilection. Approximately 6 per 1 lakh, aka Steele Richardson Olszewski syndrome, Parkinson plus syndrome. PSP is basically Parkinsonism plus impairment of vertical gaze. PSP is equals to Parkinsonism plus impairment of vertical gaze. PSP plus impairment of vertical gaze seen in progressive supranuclear palsy. Horizontal gaze impairment sometimes seen as the later disease progresses, but would be atypical in a newly diagnosed patient. So in this palsy, you can read, you can go downstairs, you can see properly when moving down. Okay, features. Okay, impairment of vertical gaze, down gaze worse than up gaze. Patients may complain of difficulty reading or descending stairs. Parkinsonism will be there, falls will be there, slurring of speech can be there, cognitive impairment can be there. Poor response to L-DOPA. Dementia, very important topic as well. Dementia is thought to affect over 850,000 people with dementia in the UK, with numbers set to rise over 1 million by 2025, and it accounts for a large amount of health and social care spending. In the UK, 1 in 6 people over 80 have dementia. The most common cause of dementia in UK is Alzheimer's disease, followed by vascular Lewy body dementia. So vascular is second, Lewy body is third. Okay. So Lewy body dementia, as you know, there's hallucination, and vascular will see multiple stroke-like features. Okay, anyway, diagnosis can be difficult and is often delayed. The mini mental state examination is widely used. A score of less than 24 out of 30 says dementia. And management in primary case care, blood screen is usually sent to exclude reversible causes like hypothyroidism. NICE recommends the following tests like fasting blood, full blood count, urea and electrolytes, LFTs, calcium, glucose, TFTs, vitamin B12, folate levels. Patients are now commonly referred to an old age psychiatrist rather than sometimes working in memory clinics. CT brain in secondary care. Neuroimaging is performed to exclude other reversible conditions like subdural hematoma, normal pressure hydrocephalus, and help provide information on etiology to guide prognosis and management. Lewy body dementia is an increasingly recognized cause of dementia, accounting for up to 20% of the case, and so this is something to watch out for. The characteristic pathological features is cytoplasmic neuronal inclusion, called Lewy bodies in the substantia nigra, paralimbic and neocortical areas. So this will be available in all these areas. The relationship between Parkinson and Lewy body dementia is complicated, particularly as dementia is often seen in Parkinson's disease. Also, up to 40% of patients with Alzheimer's have Lewy bodies. So this is all confusing up, okay? Because in Parkinson there's dementia, and then there's Lewy body dementia, there's Parkinsonism, so all mixed up, correlated. Neuroleptics should be avoided in Lewy body dementia as patients are extremely sensitive and may develop irreversible Parkinsonism. So important. Questions may give a history of patient who has deteriorated following the introduction of an antipsychotic agent. So once you give antipsychotic agent, you may have this worsening of Lewy body dementia. So what are the features then? Progressive cognitive impairment, so basically like dementia. Parkinsonism, which is causing the problem here, it's having Parkinsonism which is not there in dementia. And visual hallucination, delusion, non-visual hallucination, all type of hallucinations are there. So if you compare this with dementia, of course, you know dementia features, and then there's progressive supranuclear palsy where there's Parkinsonism and impairment of vertical gaze, easy as that. MSA will have Parkinsonism, autonomic disturbance, and cerebellar signs, which is a bit more difficult to remember. Alzheimer's disease, this will be there in geriatric disease, that will be very nice to remember. Okay, so Alzheimer's disease is a progressive degenerative disease of the brain, and most cases are sporadic. 5% of are inherited as an autosomal dominant trait, and mutations in the amyloid precursor protein chromosome 21, presenilin 1 and presenilin 2 genes are thought to cause the inherited form. and apoprotein E allele 4 encodes a cholesterol transfer protein. So pathological changes is macroscopic and widespread cerebral atrophy, particularly involving the cortex and the hippocampus, microscopic interneuronal neurofibrillary tangles, neuronal plaques, and deficiency of neurons. Biochemical deposition of alpha beta amyloid protein in the cortex, deficit of acetylcholine from damage to an ascending forebrain projection. Neurofibrillary tangles is basically paired helical filaments are partly made from a protein called tau. In Alzheimer's, tau proteins are excessively phosphorylated. Tau proteins are proteins that stabilize microtubules, and they are abundant in the neurons in the CNS and are less common elsewhere. When tau proteins are defective and no longer stabilize microtubules properly, they can result in dementia such as Alzheimer's. Okay, stabilize microtubules. Okay, management is basically donepezil. Nice. Now recommend the 3 acetylcholinesterase inhibitor like donepezil, galantamine, and rivastigmine as option for management of mild to moderate Alzheimer's disease. Donepezil may cause bradycardia and AV node block, so be careful with that. And memantine is served for patients with moderate to severe Alzheimer's. Okay. Next is frontotemporal lobar degeneration or Peak's disease. Basically, Peak's disease is a frontotemporal lobar degeneration disease and progressive neurodegenerative disorder comprising of dementia. Memory is less severely affected than in Alzheimer's. And insidious behavior and cognitive symptoms. Insidious behavior and cognitive symptoms like aggressiveness and inappropriate behavior, stereotype behavior, apathy, and depression. Speech and language abnormalities may begin early and progress rapidly. Brain CT or MRI may show selective areas of atrophy of the frontal and temporal lobes. Mini-mental score is often surprisingly high and more formal neuropsychological testing may be required to establish the typical cognitive deficits. 50% of cases have an affected family member. A subgroup of patients with frontotemporal dementia has symptoms and signs of motor neuron disease. This is evidenced by the lower motor neuron signs of impaired swallow, proximal limb weakness, and fasciculation indicating recent innervation. And treatment is supportive. Symptoms and motor neuron disease symptoms and signs. This is evidenced by lower motor neuron signs of impaired swallow, proximal limb weakness, and fasciculation indicating recent degeneration. So we will be in dementia, and there's aggressiveness and mini-mental score will be surprisingly high, and with some signs of motor neuron disease as well. Creutzfeldt-Jakob disease. It's a fatal degenerative brain disorder. It's believed to be caused by a protein called as prion. Infectious prions are more misfolded proteins that can cause normally folded proteins to become misfolded. So most cases occur spontaneously, while about 7.5% cases are inherited from person to person on autosomal dominant fashion. So it's misfolded protein prion. What happens is basically rapidly progressive, severe, and invariably fatal, usually within minutes to months. Dementia, cerebral ataxia, diffuse myoclonic jerks, and other abnormalities. So myoclonic jerks, cerebral ataxia, dementia. So myoclonus is typical and progressive even during the later stage when the patient is stuporous or comatose. So myoclonus is typical and progressive even during the later stage when the patient is stuporous or comatose. Okay, EEG. The investigation, the EEG pattern is characteristic. Diffuse non-specific slowing periodic sharp wave complexes, PSWC, the S of 1 to 2 Hz, but diagnosis relies on either specialized test for prion protein or diagram biopsy. Alvin assigned on cranial MRI, 90% pathological and CJVD, non-sporadic, prion proteins in tonsils, 14-3 protein in CSF, sporadic CJD predominantly affects late mid-aged individuals with mean age of death in the late 60s. Memory impairment and cerebral ataxia are common early features, subsequently rapidly progressive dementia and myoclonus. So myoclonus dementia ataxia, myoclonus dementia ataxia, MDA. Or you can just keep it like this: CJD, MAD, MAD, right? Mad cow disease, right? So it's MAD, CJD, mad cow disease. So remember that: myoclonus, ataxia, dementia. Okay, so memory impairment and cerebral ataxia are common early features, subsequently rapidly progressive dementia and myoclonus. The median duration of illness is 4 months, and 65% of cases die within 6 months. Sporadic form: memory impairment and cerebral ataxia are common, dementia, myoclonus. Bovine spongiform encephalopathy or mad cow disease spread to the humans is believed to result in variant CJD. Okay, coming to a very important topic of cerebrovascular disease, we'll have ischemic stroke, TIA, and all those strokes and hemorrhages that are there.